Hello, everyone. My name is Dr. Joseph Sullivan. I'm happy to be here with you today virtually to give this overview on some of the sleep, behavior, and cognitive issues that affect our patients and families living with Dravet syndrome. Here are my disclosures. And so first, I just want to go over an outline of what I'm going to try to cover in these next 25 to 30 minutes. I first will review the longitudinal studies that have been done in Dravet syndrome patients looking specifically at cognition and behavior. I'll then review a few of the studies that have been done looking at sleep patterns, as well as some of caregiver concerns. And I'm sure many of you who are watching may have actually even participated in some of these surveys. I then am going to close with a summary of the preliminary findings that we reported on in the Prospective butterfly study, which is a prospective natural history study to evaluate a lot of these other non-seizure related endpoints that are very important to us in the care of our patients. And maybe this should have been actually a disclosure. This really is going to be more of an overview of what we know. I don't want to sound pessimistic, but right now we still don't have really specific data-driven approaches about how to improve all of these things. But I will say that I'm optimistic that with all of the progress that we've made in the last 5 to 10 years with new compounds and some other new agents that are in the pipeline, I'm hoping that we really can start to improve upon some of these other issues. So first, just a little bit of background. Children with epilepsy have long been known to have more difficulties with behavioral, social, emotional, and cognitive functions. And even as I was preparing for this talk and being a neurologist, the word cognition is kind of a loaded term. And so I thought it would be helpful just to put up a definition here so that we're all on the same page. And maybe this is a little bit more philosophical and nuanced than needs to be, but cognition, simply defined, is a mental action or process of acquiring knowledge and understanding through thought, experience, and the senses. So, I broadly think about it as this is our kids, this is us going to school each day, going to work each day, and living our lives in the way that we can as human beings to learn things and implement what we learn in our day-to-day life. So with that, we know that these difficulties can have a major impact on health-related quality of life. I've said in previous talks, although our patients do still have fairly frequent seizures, if you do add up the total number of minutes or hours in a specific week when a child or a loved one with Dravet syndrome is spent seizing, that pales in comparison to all of the other waking hours where the person may be impulsive or may be hyperactive or who may not be sleeping well. So it's very clear that all of these issues related to cognition, behavior, and sleep are critically important to not only the quality of life of the patient, but of the caregivers as well. And then, the big question is there something specific about patients living with Dravet syndrome, whether they be SCN1A mutations or not? Is there a specific neuropsychological phenotype? And I'll just maybe cut to the chase, is that still being sorted out? There probably is a specific phenotype, but right now, for the purposes of what I'm going to present to you, you're going to see that there is just a lot of overlap with what is seen in a refractory pediatric onset epilepsy population in general. And then lastly, this is the question that parents always ask us as we're trying to think about getting patients to a better place, not only with seizures, but also with some of these other non-seizure related comorbidities, is why are these difficulties happening? Is it the seizures? Is it actually the underlying SCN1A mutation that results in the dysfunction of the sodium channel? Is it medication? I always kind of say that it probably is a combination of both. So we try to focus on on the things that we can modify in 2021, which really are seizures, and to do that in a way with medications that cause the least amount of background side effects. But there are obviously some new therapies that are currently in the pipeline that may actually be able to get at the underlying results of the genetic abnormality. So let's start with intellectual disability. This is a very well done study by Andreas Brunklas, who looked back in 2012 at a very large cohort of 241 patients with Dravet syndrome. And what this figure is basically showing is the degree of intellectual disability across the age span, beginning in the first year of life all the way out into adolescence. And what you can see is what we have long understood and known, is that the majority of children that present with Dravet syndrome in the first and second year of life are developmentally normal or have mild learning disability. But then after about that second year of life, you can see that the orange here, which is where we want our patients to stay, becomes lower and lower over time, and the sort of green and purple increases over time, suggesting that there is this regression or so of skills. But what has actually been sorted out is that in most cases, it's actually not a regression. Rather, we have expectations in a developing child that they continue to acquire skills at a certain rate. However, in our Dravet syndrome patients, they are not acquiring those skills at the same pace. So they continue to fall farther and farther behind. And then when you divide that by their underlying chronological age to come up with what we call a developmental quotient. So if you're 1 year of age and you're acting like a 1-year-old, then your developmental quotient is 100. But if you are 10 years of age and you're acting at the level of a 5-year-old, then your developmental quotient there is 50%. So you can see you're still making gains, but relative to your peers, that is actually becoming farther and farther behind. And then if we look at that even more closely in this same study, they looked at some different aspects of non-seizure related issues, namely autistic features, behavior problems, and the different some motor disorders. And you can also see that over time, as the children get older, these features become more and more prevalent. So what is this telling us? I think that this is telling us that early on, when seizures are very active, and maybe when the role of the normal functioning sodium channel is important at this time when so much important brain development is going on, that really is our opportunity, our best opportunity, I should say, our best opportunity to try and achieve some sense of normalcy so that we can start to shift this curve and avoid this increasing prevalence of this intellectual disability, behavior problems, and motor disorder over time. And then thanks to Dr. Brunklas for sharing this unpublished data with me that was presented at a meeting last year. So this is actually a 10-year follow-up of some of the patients in that original cohort. So you can see here the N is down to 70. And so in the first figure here, you can see the 2009 original study. Those were the patients that had mild, moderate, severe, and profound learning disability. And then fast forward 10 years, you can see that unfortunately, that trend continued with a very small percentage of now adolescents who are falling in the normal to mild learning disability range. And the same holds true for the figure below this with the green, blue, and orange. You can see that the percentage of patients that had autistic features, behavior problems, or motor disorders also increased over time. And then in this sort of graph to the right here, you can see how those actual trajectories do as a group flesh out over time. So now we are getting into adolescence and young adulthood, and you can see the slope of these lines is something that we as clinicians and as families want to try and alter. We don't want there to be this steep decline that happens in that first sort of 5 years, and because then it seems like it's very difficult to come back up off that line. So I don't mean to start out in a way that sounds so pessimistic, but this just showing that this is where we are in the current state. Although I will say that this follow-up being done in 2019, there have been some new medications that have become available just prior to 2019, and it's my sincere hope that as we start to diagnose earlier, engage in more syndrome-specific treatment earlier, that we will start to affect the slope and the curve of this line. One common thing that a lot of my patients ask me is they go out and they read and they see the spectrum, right? So if I go back to this slide, everyone says, well, how do I know if my child is going to be in the orange or the sort of light purple there and be normal to mildly impaired? And unfortunately, there's not some specific crystal ball that allows us to predict that with a high degree of certainty. However, in this study, they were able to look, because it was a big cohort of patients, they were able to look at some variables that at least were more commonly associated with a worse developmental outcome. So again, this isn't like if you have A, then you're going to fall in the orange, or if you have B, you're going to fall in the purple, but rather trends that if you have these or don't have these, it may suggest a slightly better or worse outcome. And so those are, and these are just mainly simple yes, no. So was there prevalence of a motor disorder, whether that be tremor, some dystonia, abnormal gait? If the answer was yes, then those patients tended to have a worse developmental outcome. An abnormal EEG in the first year of life, if yes, also more likely to have a worse developmental outcome. And I won't go through everyone, but status epilepticus, age of delay, and then this one I'm going to get into a little bit is the age of onset of myoclonic seizures. It's unclear, at least in my mind, why this would be the case. We generally don't feel that myoclonic seizures, they're 500 milliseconds, less than 1 second in duration, even when they're frequent. We generally don't feel that they actually cause brain injury or cause interruptions in normal brain development, but perhaps there's something different about those patients, and still yet to be understood why, that manifest as having early myoclonic seizures that may portend a slightly worse developmental outcome. Again, I don't want to create unnecessary anxiety here. This doesn't mean that if you do have early onset myoclonic seizures that it guarantees you're going to have a worse developmental outcome. And on the converse, it also doesn't mean that, oh, my child has never had myoclonic seizures, they're going to do better. Again, these are just associations and trends that we're trying to make sense of, so that if we understand the trajectory, maybe we can intervene at different times for different types of patients. Interestingly, things that were not predictive of outcome were the mutation type. That's a very common question that families ask me is, okay, can't we just look and see out there in the database how many other kids have my child's exact mutation and reach out to their doctors and see what they're on and how they're doing and what things work best. Unfortunately, that's sort of what we would call genotype-phenotype correlation is not very strong in our Dravet syndrome patients. And then looking at whether or not the initial seizures were provoked or unprovoked. And when I say that it's either by fever or illness, so just an upper respiratory infection that didn't have fever. So you can see a large percentage, and you are all living this, so you full well know that our patients are sensitive to fever and illness. And so up almost 60% did have seizures in that setting. Another third didn't seem to have any known precipitate. And then a small percentage, so less than 10%, it was provoked by a vaccine. But interestingly, none of these features were actually predictive of a better or worse or more favorable or less favorable developmental outcome. I do want to touch a little bit on the vaccines, especially in the setting of this pandemic and this sort of new world that we've been living in. And there's a lot of, I think, mixed feelings out there still about vaccines. And so I acknowledge that this is a very personal and a very emotional issue. But I do feel that we have data to help guide us in a way that can ensure that our patients are going to be safe and protected from some of these natural illnesses by administering vaccines. And so essentially this study was published back in the Lancet in 2010 that looked at a cohort of patients with Dravet syndrome where they had data on when vaccines were given and also when their first seizures were given. And as we know, patients with Dravet syndrome will often have their first seizure between sort of 5 to 8 months of age. And we know that's also a very common time when our kids are getting on their regular vaccine schedule, requiring a lot of vaccines at 2, 4, 6 months. So the big question comes up, is this just, two ships sort of passing each other and it's just a coincidence? Or is it something that the vaccine actually is causal or triggering? I think it's very, very well established and accepted that it is not causal, but that it actually is triggering. Much in this, as that said on that previous slide, we know that some of these seizures can be provoked. And so if you look at this figure here, you can see these are all of the patients that had data about a seizure and how that related to the timing of their vaccine. And what I'll call your attention to is just kind of this peak in the 0 to 5 day range. And so you can see that there does seem to be a small percentage of patients that do have their first seizures in the setting of those first few days of the vaccine. And so the authors of this paper basically defined vaccine proximate, meaning the seizure occurred close to the vaccine as being 2 days, and then vaccine distant as being everything else that you see here. And so what you can see, again, is that there is that little spike, but there are many other patients who either did not have a seizure at all associated with the vaccine. Some of them even had it before their vaccinations, or if they did have it, it was either weeks to months later. So then the question is, okay, I'll give it to you, Joe, that the vaccine didn't cause my child's SCN1A mutation and therefore Dravet syndrome, but what about, could it actually have made things worse? And thankfully, we also do have data about that. And so here's a figure that's taken from this paper that, again, this is a total of 40 patients. So I'll give it to you small numbers, but numbers that at least we have good data on. And you can see, as I just alluded to on that prior slide with the figure, that those that are in the vaccination proximate group, that their age of onset in terms of their first seizure was about 8 weeks earlier. So they presented at about 18 weeks as the first seizure compared to 26 weeks. And this little p-value over here says that is statistically significant. And then if you just look down at the convulsion types, I mean, there really is no difference between the types of seizures, the episodes of status epilepticus, but most importantly, the developmental outcome. So if you look at the number of patients, again, in the vaccine proximate column, who were in the mild, moderate to severe versus the vaccine distant, you can see that those percentages are very, very similar. So I think the majority of my colleagues feel very, very strongly that while the vaccination may be the initial provoking factor in that initial seizure, it in no way alters the ultimate course that our children take with Dravet syndrome. So again, staying on this theme is, how is my child going to do? Are there other predictive factors? I mean, in the field of clinical epilepsy, we kind of pride ourselves on trying to find these patterns and make a syndrome diagnosis, and then within the syndrome, try to understand if it's evolving in some way. Does that actually shed any light on how that person is going to do? And I know we focus a lot in some of our talks. As a pediatric epileptologist, I always have to be careful that I always say children, children, children. And I know that there are many of you that are probably watching now that have young or older adults that you are caring for with Dravet syndrome. And trust me, we are not ignoring you. And we do want to try and better understand how the condition is different in adults. And so this study here looked at two groups of patients, basically a group of 34 adolescents and 50 adults, and just tried to look at just some clinical features as to what predicted more severe developmental outcomes and cognitive impairment versus less severe. And again, a lot of these are being done retrospectively, so not being done with the same exact assessments, but I think it's still valid. If we have the data to report out on how these patients are doing, that we certainly should do that. And so one big sort of lumping and splitting that this paper did here is they looked at the myoclonic phenotype, so basically patients that were having myoclonic seizures and absence with myoclonias, so the staring and the sort of jerking of the heads and the shoulders, versus those that did not. And essentially, if you were to look at this figure here, as well as the age of onset of these myoclonias. And so what you can see is that in those that had the MM, which are the massive myoclonias, onset prior to 5 months of age, that they were more likely to have more persistence of seizures in adolescence and adulthood, and more cognitive impairment compared to those that actually had no massive myoclonias greater than 5 months of age. And then if you actually look at just the age of presentation, the 5-month mark also seems to be this sort of, I don't want to say it's arbitrary, but it is actually arbitrary because we're basically choosing it based on the data that was in this study, that seems to be early versus late onset. So those that present a little bit later, say they have their first seizure at 9 months of age, maybe that is something that is a more favorable prognostic feature. So putting this together, basically the presence of myoclonias, absence of myoclonias, or reflex seizures, so we know that our patients can have pattern seeking and light seeking, that did, unfortunately, correlate with higher seizure persistence in adulthood, as well as a higher severity of intellectual disability. And that also younger onset, and again, I'm sorry if I confused anyone in terms of how this figure is worded. It's the onset, meaning the onset of the first seizure, less than 5 months. That also tended to be a predictor of more severe disability. Again, not to beat the same drum. These are trends. It does not mean if you're less than 5 months presenting that you will do worse, or greater that you will do better, but rather those are sort of risk factors that may suggest the trajectory further on. Okay, so I've been talking a lot about what many of you already probably know and feel and are living it, and I think this also you are living it. Is why does all this matter, right? All this matters because we know that seizures and behavior and cognition and the level of intellectual disability can have a huge impact on the quality of life for the patient, the caregiver, the extended family, and we want to try to understand what is driving that, right? Because if we can just improve seizures, but quality of life doesn't improve, that's still obviously something we should try to do. But how can we start to get at the holy grail here of improving on quality of life? So in another study done by Andreas Brocklaus and his group, looked at these different questionnaires that were submitted, that were given to a number of families, 163 families, and just really looking at the impact of epilepsy, a generic health-related quality of life, strength and difficulties, et cetera. These are the different assessments that were done as part of this study. And the epilepsy severity scale, these are pretty simple questions to answer, right? How severe have your child's seizures been? And they could rate it on a scale of 1 to 4. How well do you think they've been controlled in the last 4 weeks? How concerned have you been about your child? And then all of these scores were summated together and averaged, and then they were assigned a category of very severe, severe, moderate, or mild. And so the strength and difficulties questionnaire really looks at some of these, what I would say are critically important domains in all patients, but particularly in children. We know our children have to go to school. They have to make social relationships so they can have friends. And so this is really looking at conduct, hyperactivity, and peer relationships. And so again, another table taken from this particular paper that tried to look at all of these different variables, so age at first seizure, a motor disorder, learning difficulties, and to try and see how those correlated with the epilepsy severity and overall health-related quality of life. And so what we can see here, they all, for those parents and observers here that aren't familiar with statistics, a p-value of less than 0.05 is considered statistically significant. And the more and more you get below that, the more strongly significant that is, and is unlikely to just be occur by chance. And so you can see all of these p-values are highly significant, which shouldn't surprise us, because the majority of our patients with Dravet syndrome do have myoclonic seizures. They have episodes of status epilepticus. They have these. So then the key is to try and figure out, are there any of these that are really driving the primary driving point? So if you correct for one element, does one other element stand out? And that's what this final bar here in terms of epilepsy severity and the SDQ score. So patients who, and again, I hope this doesn't sound insulting, it's like, well, Joe, that's obvious. Of course, epilepsy severity is going to have a direct correlation with quality of life, but it doesn't. That doesn't always necessarily have to be. And what you can see here is that correcting for all of these different variables, that the epilepsy severity and the SDQ score did predict the overall health-related quality of life. And then when you actually looked at all of the ones that came out still as being significant, all of them except status epilepticus were part of that. And we could go. We don't necessarily have time to go into why that may or may not be, but I think that it's very clear here that while we want to focus a lot on sleep, behavior, and cognition, the epilepsy severity is still important to address. And then this is kind of my last slide before we move on to the next sort of section. This is one additional large cohort of Dravet syndrome patients in Europe, where 584 completed a survey. You can see in the pie chart here the difference in ages. So we have the majority are in the preschool to middle childhood age range. And again, trying to get at that seizure severity, to look at then in the bar graph here, in the sort of brown, dark brown, it's the highest convulsive seizure frequency, that quartile, compared to those that had the lowest convulsive seizure frequency. And you can see that when we look at those, things like learning difficulties, autism, other behavior stuff, it's kind of similar between the two. But maybe there is this pattern that those that have a higher seizure burden do have a tendency to have more motor impairment and have more speech impairment. Okay, so to sum up the behavior and cognition part, I hope I've shown you that these difficulties are very common in children, adolescents, and adults with Dravet syndrome. There may be some correlation with age of onset in the existence of myoclonic and absence seizures. And again, I want to highlight that I personally don't believe that it's the myoclonic and absence seizures that are causing this sort of correlation, but rather is there something different about that particular patient that is having that seizure type that puts them at increased risk. And again, I think that still needs to be sorted out. That behavior and cognition do impact the overall health-related quality of life just as much as seizures. So I think we need to figure out a new term for us as epileptologists, because we are caring for more than just the seizures and just the epilepsy. And we do really want to start paying very, very close attention to these other non-seizure related issues. And I do feel that myself and many of the others who you've already heard speak at this conference, that efforts are underway to try and, now that we're having a better understanding and that we can actually test these patients and understand what is going on, now we can start to brainstorm a little bit about maybe syndrome-specific interventions that will hopefully get our patients to a better space. Okay, so transitioning now over to sleep or lack thereof, and I don't mean that to be a joke, but I often will say to my fellows and even to my patients that I'm always reluctant to ask about how their child or how they for that matter, are sleeping, and this is Dravet or non-Dravet, because I very often already knew the answer that the overwhelming majority sleep is not great. So we do know that this is sleep issues are much more common in patients with epilepsy than when you compare to other childhood onset chronic disorders. However, in patient surveys and feedback that we are hearing from you, there was this feeling that the reported prevalence in Dravet syndrome seemed to be higher. Why is this? There are some animal models of Dravet syndrome that do demonstrate sleep disorders, and some people hypothesize that maybe it's because of this impaired sodium current that's occurring in this region of the brain called the reticular nucleus of the thalamus, which is thought to help regulate sleep. That if that's dysfunctional, then perhaps that leads to disrupted sleep. Again, this is more on the basic science side and needs further work. But this was another study that was done looking at specifically sleep survey in questionnaires of 56 families of patients with Dravet syndrome, and this score called a Composite sleep index was calculated. And basically, this is a validated questionnaire that looks at sleep disorders, and a score greater than 4 indicates a severe sleep problem. And really, the questions are targeted at: is it a problem settling down? Is it a problem with night waking, early waking, or actually the duration of settling and night waking? And so here are the results, and this is interesting. So in this Dutch study, about 20% reported that that parent or caregiver co-slept with the patient. This is in contrast to a study that was mainly US-based, the Dravet Syndrome Foundation, that actually reported this was up at 80%. So interesting sort of demographic difference there. 50% used some type of nocturnal monitoring system, and this was also higher in the US based survey. And you can kind of see the breakdown there of the different types of devices, the most common being pulse oximeter, the second followed by MFID, and the third followed by SAMI. And these are proprietary devices that can be purchased that are really getting at sensing motion and movements that can be suspicious for a seizure. And so what were the composite sleep index scores? So about 20% said that they had difficulty getting their child to sleep at least greater than or once per week. But 75%, at least again, in this one survey, said that their child or loved one fell asleep relatively easily, which they defined as less than 30 minutes. Unfortunately, so you get them to sleep, about 60% would wake up regularly, again, more than once per week, and often 2 or more times per night. Thankfully, the majority of those that do fall into this, who have the frequent wakings, do again fall asleep easily. But already, as I'm even saying this, I'm getting tired, right? You think, okay, I finally got them down, they're asleep, oh, they woke up. So this isn't still a great night's sleep, right? Thankfully, the majority are falling back asleep. I really feel for those families that come in and say, yep, Johnny, he woke up at 4 a.m. and he's just ready. He's ready to get up and go. And we don't have great interventions to sort of target that type of pattern. And interestingly, a lot of the kids, even though they're getting this fragmented sleep, a lot of them still, the families at least reported that they found their child awake and refreshed the next day. And the last sort of bullet point that came out of this take-home message from the study is, about 30% did have a score greater than 4, which did indicate a higher sleep disorder, a more severe sleep disorder. And interestingly, the 2 variables that came out in those patients were that they were more common to co-sleep. And again, I'm not passing any judgment. Co-sleeping, it has its advantages, it has its disadvantages. But one of the theories here is that it's a little bit circular. Maybe someone who had a child or a patient who has more severe sleep problems, the family is just like, okay, I'm just going to give in and I'm just going to sleep with them. It's just easier for me to roll over and soothe them. And so maybe that's the factor. Or is it also that the co-sleeping is potentially contributing to the more disruptive sleep. Again, I don't necessarily have a strong opinion on that. I know it's a very personal choice, and certainly I want to encourage you all to do what works best for your family. And then interestingly, it was more common that those who had a higher composite sleep index score were more commonly on stiripentol. Again, I don't want to say that stiripentol is causing these sleep issues. This is an association and something that I think certainly we should be aware of as we're thinking about adding stiripentol to someone's medication regimen. And so getting back to the initial comment, are patients with Dravet really any different than other childhood onset epilepsy? And I don't really need to spend a whole lot of time on the slide, but just to look at the top figure is Dravet, the bottom figure is non-Dravet epilepsy, other epilepsies, and you can almost see that it's a mirror image of the two. So, so we know that sleep issues are a problem in patients with epilepsy. Maybe there are some nuances in terms of different subtypes of whether it be settling or frequent waking that may affect Dravet patients a little bit differently. And I think the more that we start asking these questions and the more that we come up with tools to try and tease it out, it may help us develop some specific interventions. So on the intervention front, what about treatments? Everyone's waiting, right? Okay, Joe, tell me what I can do to help my kid get to sleep. Well, sadly, this is I don't want to say funny. It's embarrassing, I guess, in a way, because 60% never received any advice regarding sleep problems. And I don't think that's because we as physicians are ignoring it. I think that we feel, or I'll speak for myself, I feel uncomfortable getting too much into the weeds about it because there's not a whole lot of options. And that was actually corroborated in this study, that even if they did receive advice, it was often not effective. And often the interventions that were tried, there are, I'm sure, many of them that you have tried yourselves, melatonin, antihistamines, and benzodiazepines. And so I think that there probably is a reluctance on the part of providers to really get into this, because it ends up just being frustrating for us as well, to say, yeah, I hear you, your child's not sleeping well, you're not sleeping well. We kind of just have to go through, try a routine and a little bit of trial and error and try to figure out what works for you. But I do think we need to, I've learned so much from all of you as taking care of different families, different ages, different age of diagnosis. I've learned so much about what you are experiencing. That I think the more that we engage in this dialogue, the more we as providers will become more skilled in terms of knowing which questions to ask, and maybe then come up with some types of interventions that may be effective. So now, are we moving into a new era? We're in 2021 here. It's been obviously a challenging year with the pandemic, but we have continued to move forward and try to improve upon the treatment options that we have for our patients. And there's a really exciting time because there are some novel treatments that are in the pipeline that again, trying to get back to that seizures versus the SCN1A. So how can we restore that normal SCN1A function so that maybe that'll give us the best chance to have a improvement in these developmental comorbidities. And so this new era, a lot of the studies that I've presented to you so far have been retrospective, right? So going back, looking at the charts, looking at our notes to try and figure out which kids are doing better, which kids are doing worse. We are definitely getting better at making this diagnosis earlier. 5 years ago, it was not uncommon that I would have a patient referred to me age 3, 4 years old, just for a second opinion for treatment-resistant epilepsy, and I would make the diagnosis of Dravet syndrome. Now patients are coming early. They're coming at 12 months of age with a diagnosis of Dravet syndrome to get a second opinion about that specific management. So I do think that our ability to get genetic testing, I think that the awareness that's out there, while it still can always be improved, is much, much better than where we have been. And in my heart of hearts, I have to think that this is going to help us achieve better outcomes, because we're going to know a framework, and we're going to be able to choose some of these syndrome-specific medications rather than approaching it more broadly. And so there is a need, though, to understand, in a current population, right? The study that I presented to you from Dr. Brunklaus going back to 2009, and the follow-up, these are patients that very likely had a more delayed diagnosis than what we're seeing now. So what are patients going to look like now, like in 2019, 2021, that are being diagnosed now, and treated with the knowledge that they have Dravet syndrome? How do they develop over time? And so I'm going to present to you 3 or 4 slides here from a study that I was involved in called the Butterfly Study, and this was sponsored by Stoke Therapeutics, really to try and do a small prospective natural history study. One, to see what types of tests can these children complete, so that we can get sort of usable data, and if they can complete them, are there some patterns that we can see over time? So this first assessment is called the Bayley Scale of Infant Development. 13 patients were able to complete this. And as you can see, so if you just look at all the dots here on the figure, you're going to see that on the x-axis here, these are patient age, and on the y-axis, these are the raw scores. So this is not a percentile, this is an actual raw score. And so what we would like to see, right, is that as the patient ages, you're actually scoring better on this test. So there should be a gradual line going from the bottom left up to the top right. What you can see is that's not happening in these 13 patients. You can see that the cognitive scores, although the dark blue dots on the top kind of stay stagnant, the light blue are gross motor, the fine motor, there's a little bit of scatter. But then if you look at the language, so you look at the orange dots and the gray dots, and you can see that there is a subtle sort of trend of acquisition of skills. And so that's what we do see, right? We know that our patients do acquire skills. And so it's our job, I think, to try and intervene in a way that increases the chances of this slope continuing to go in that direction. This is also takes into account the developmental quotient. So now this is that math problem, right, where you're dividing the age by the score, and you can see again that the developmental quotient declines over time. But if we went back right to this previous slide, if these things are staying the same, it's actually not a regression. It's just for some of these domains, a lack of acquisition of new skills. So then when you divide it by an older age, when our expectation should have been that there had been progress, these developmental scores go down. So that's important to understand. I think that is something that we have understood, but this is at least confirms that in a prospective manner. And then there's another test. The way that this study was designed is that if you could complete the more complex test in a certain number of items, then that was the test that was done. But if you couldn't complete, then you went down to sort of an easier test. So this is the test that has a little bit more expectations, and you can see you can get into a little bit more of the details here. You can start to look at block design, you can start to look at picture memory, you can start to look at this thing called a bug search. So 9 patients completed this. And again, you can see this general trend. And so this almost becomes a little bit of a self-fulfilling prophecy. So these kids are already higher functioning to the point that they can actually complete this assessment. But once you're higher functioning, right, you can actually see that there is an acquisition of a lot of these skills over time. So it speaks to me that we do have the opportunity to improve here. A couple more slides. If we just look at the Vineland adaptive behavior skills, so these are looking at a whole other list of functions in the communication domain. We can again see a lot of variability, right? So if you just look at the 8 to 12-year-old group here, there's scatter, there's scores that are, and again, these are raw scores, not being divided into some quotient. Scores down here at 10, and then all the way going up to 70. So big scatter, but again, some consistency that there is this kind of plateau over time. And then lastly, just to look at some of the subsets of these, you can see that in these young patients, they tended to do score the best again in this small study. So again, getting to that earlier is better, early diagnosis, early syndrome-specific treatment, and then hopefully some new disease-modifying therapies that are in the pipeline. If we can intervene, then then do we have the opportunity to get in the way of this fairly common developmental plateau. So in summary, I hope that I've showed you that Dravet syndrome is a syndrome that encompasses much more than just seizures. We know that kids start off developmentally normal and then most plateau over time, and that time tends to be at around age 2. So I think that's certainly a time point that we are all focusing on, to say that that's at least a time where we have to intervene, and maybe even sooner is going to be better. While I don't have any specific long-term data to show you that would support this, I think it's our general feeling that again, early diagnosis and appropriate treatments is going to reduce epilepsy severity, and then maybe that will have less of an impact at this critical window in infancy when the brain is undergoing such important developmental changes. It's obviously, we cannot ignore, though, the role of the reduced sodium channel expression, and I think that we are really not going to be able to sort of move mountains until we can address that. And thankfully, I think in the next few years, we are hopefully going to have some data to support some of these new therapies, and hopefully we come up with a new treatment paradigm that can again be addressing not just the seizures, but all of the other issues that are affecting these patients. And my last point here is, again, we always focus, or I shouldn't say always, we tend to focus on children. I think that there have certainly been observations in my clinics and my colleagues' clinics of making a diagnosis of Dravet syndrome later and starting them on more specific therapies, even in young adulthood, and they can make significant gains. And so even though we are focusing on earlier is better, it's my hope that as we come into some of these potentially disease-modifying therapies, that it's still not going to be too late for those patients to experience some benefit as well. So thank you for your time.